So just a little bit about the webinar. It's a 1 hour slot just to give you snippets of education around nutrition in cancer, pediatric cancer. And our first webinar today is going to be presented by the team in Ireland. I'll let them introduce themselves in a moment. Um, what we'll do is we will not ask questions, we'll let them present the whole thing. And then at the end of it, we'll open up to questions and panel discussion. So this is where I would expect all attendees to participate, interact. And you can then turn on your cameras if you are asking a questions or you wish to participate in the discussion. Okay. Any questions, please note it in the chat. Thank you. So I now invite speakers. Over to you. I'm going to mute my phone and stop sharing. Thank you very much.
Mary, thank you so much for the kind introduction. I'm honoured to be asked to join a nursing educational webinar series. I'm a paediatric oncologist based in Dublin, and I'm joined by 3 of my wonderful colleagues from the multidisciplinary team. And it's our pleasure to share our experience of how we support our children as they go through their arduous treatment in the best way that we know from a nutritional perspective. I'll just share that we have no conflicts of interest. And then it's my honour to be able to give you a little bit of background about who we are. We all work in the National Children's Cancer Service, serving the whole of the Republic of Ireland. And we're based over here on the east of Ireland in Dublin. But all patients within Ireland with a malignant diagnosis travel to us for most of their diagnostic workup and administration of most of their treatment. And you can imagine that's a long drive from West Cork to Dublin or from North Donegal down to Dublin. And for that reason, although we are the main centre for the country, we share care with 16 centres around Ireland. And the idea is that no patient will be more than 1 hour away from their local hospital where they can receive emergency care, for example, for febrile neutropenia. But we also link in very closely with the MDT in those local hospitals to help support our patients' nutritional needs as well. We're based at Children's Health Ireland at Crumlin, which is in Dublin. The population of Ireland is around 5.5 million, and that means that we see around 200 new patients per year, with the usual distribution of about 50 of them being acute lymphoblastic leukemia, 50 having central nervous system tumours, and the rest of the patients divided between sarcoma, renal tumours, etc. Our neurosurgical colleagues are currently across the city, which poses some challenges for those patients and their families, and we all try our best to work together. The good news is that we have a new state-of-the-art hospital that we're very much looking forward to moving into, and you're all invited to come and visit us whenever that happens. It won't be this year, though. So from a medical point of view, and indeed from the whole team's view, who of our patients are at risk? Well, that's easy to answer because all of them are, and often for varying reasons. We care about nutrition because it has short and long-term consequences for our patients. The short ones you'll be well aware of. It can affect their well-being, it can affect their immune system and make them more vulnerable to things such as febrile neutropenia, and all of these things can lead to delays in treatment, which of course we want to avoid if at all possible. And then the long-term consequences are mainly related to metabolic issues, general cardiovascular health, risk of osteopenia, and risk of metabolic syndrome later in life. And of course, first of all, we want our patients to survive, but we want them to survive with as good clinical condition and quality of life as possible. In parallel to us being able to deliver their anti-cancer treatment, we want them to continue with attainment of normal childhood growth, to go through puberty at the expected time, and really vitally for their neurodevelopmental needs to be met. And how do we cause problems with nutrition? Well, some of them are inflicted by us with treatments, so our protocols play a huge role in this. And you'll all appreciate that in recent years there has been a vogue for increasing the intensity of treatments. Those of us old enough in the audience may remember the days of Kojak before it became rapid Kojak. So in those days, chemotherapy was delivered at every 3 weeks. And then Andy Pearson in Newcastle had the idea of intensifying treatment and delivering it every 10 days. We've seen that happen with Ewing's treatment as well, going from 3 weekly to 2 weekly. So we're constantly bombarding our patients with intensive treatment and not giving them a chance to recover, and increasing their metabolic needs and increasing their nutritional support needs. Of course, many of the treatments that we deliver are very emetogenic and don't just cause nausea, but cause vomiting as well. Some of them will cause mucositis and GI toxicities, for example, high-dose methotrexate, and something like irinotecan, which can cause increased gut motility times, or rather decreased gut motility times. If a protocol involves surgery, that will of course impact on the ability to continue with nutrition. And radiotherapy, depending on where it's delivered, whether it's to the abdomen or to the brain and spine, certainly has consequences for continued good nutrition. And if you, on top of that, put fasting for procedures, there is a further impact. So they are the medically induced factors, but there are also many patient, family, and environmental factors that play a part as well, not least the location of the tumor. Those of you who've seen children with large intra-abdominal neuroblastoma will know that their mid-arm circumference is not what it should be, even if their weight might appear to be normal for their age. And that's because the tumor, of course, has a mass, but the rest of the child's body is malnourished. Some of the children we meet have pre-diagnosis nutritional issues, whether that's over or undernutrition, and sadly, overnutrition is becoming a more common thing that we see. We know that many of our treatments can alter the taste buds, and of course, the pleasure we get from eating is mainly to do with being able to taste things, so that impacts on the child's wish to ingest food. We're meeting more and more children who have restricted diets, perhaps who are on the neurodivergent spectrum, and that poses challenges. And then some families develop beliefs about appropriate diet during cancer treatment, with many families choosing to avoid sugar and even asking for ketogenic diet, which we don't usually recommend. Infants and young children may develop oral aversion, and it can be hard to wean them off nasogastric feeding. And then another huge challenge is access to appropriate food preparation facilities, not only whilst in hospital, but some of our families currently are refugees from other countries, and they may be housed in hotel accommodation where they don't have access to a kitchen, and that certainly poses challenges for them. So a little bit now about how we care for nutrition. We have a daily multidisciplinary team meeting on our ward. We call it the dry round, and whichever team are on service will attend that round every morning. We all join together in the same room, and there is representation from nursing colleagues, from dietetics, clinical nurse specialists, advanced nurse practitioners, medical, both consultant and non-consultant junior doctors, pharmacists, and extended members of the psychosocial team. And of course, we talk about many aspects of each patient's care, but we have a special focus on nutrition. And our aim is to provide proactive, preemptive, bespoke, and holistic care based on each individual child's protocol intensity, premorbid issues, the emetogenicity of the treatment that they will receive, and any other anticipated side effects. And with the help of the nursing team, we perform continual monitoring of nutritional status. At a basic level, we provide parental and patient education and general dietary advice, and that can be from any member of the multidisciplinary team. And then in a cascade manner, we will talk about nutritional supplements, and then we need to address route of administration of those supplements if the child is unable, for whatever reason, to take them orally. So many of our patients will end up with nasogastric tubes, or even gastrostomies or jejunostomies. We're very pro continuing with enteral feeding, and we try and avoid parenteral nutrition wherever possible, but of course, in the more intense protocols, for example, bone marrow transplantation, that may be unavoidable. But we're very big proponents of trophic feeding and continuing with the gut microbiome. How else can we help the children apart from supplementation? Well, of course, we can optimize their supportive care, both pharmacologically and psychosocially. We pay attention in our dry round and on our ward rounds with appropriate antiemetics, depending on the patient protocol and the individual patient requirements. We need to pay attention to pain control with appropriate analgesia, acknowledging that some analgesics will then cause constipation, which we need to address with laxatives. Many of the patients will receive steroids both as part of their anti-cancer treatment or as supportive care in the form of antiemetics. They may require antacids. And then for children with GI toxicity, once we've established that they don't have a GI infection, we may want to consider anti-motility agents. And a tiny number of our patients with mood disturbance may also benefit from antidepressants. From a psychosocial perspective, we involve the whole team, including psychologists. We're blessed to have a wonderful complementary therapy service, excellent play and music therapists, a very supportive social work team. The children are always thrilled to meet the teachers from the hospital school. But this is another way of diverting their thoughts away from what's at hand in terms of their treatment and hopefully improving their general well-being. We also recently have a pet visiting initiative, and the dietitians can organize social eating groups, especially helpful for the toddlers who've developed oral aversions. We're also very lucky within Crumlin to have an excellent dental team, and we involve them at an early stage. In fact, it's our aim that every new patient will meet the dental team and they can give advice about ongoing oral hygiene, they can perform restorative and preventative work, and if a patient develops mucositis, they can do some laser treatment, and they come down every day to the ward to help us with that. I'm going to hand over to my more experienced colleagues in the dietetic service, but my take-home points as a doctor attending this MDT are that it's crucial to think and talk about each patient's nutritional status with the whole MDT. Please don't be afraid to encourage your medical colleagues to be involved. Remember at all times, as I know you will, to be sensitive in discussions with patients. We don't want some patients, particularly teenagers, to become too focused on their nutrition and develop avoidance behaviors. And of course, you need to liaise with local and community supports, especially if you're in a situation like we are, looking after many patients who live distant to our centre. And with that, I'd like to thank you very much for your attention and time. And I will hand over to my colleague, Cliona Godwin, a senior dietitian.
Hello, everybody. Thank you so much for having me today. My name is Cliona Godwin. I'm a senior dietitian on the National Children's Cancer Service in Dublin, Ireland. And I suppose today I'm just going to talk a little bit more in detail on the role of nutrition and how we monitor children's nutrition status during cancer treatment. So as Jane has touched on a little bit already, you know, I suppose every child, we hope that they have adequate nutrition so that they can continue to grow and develop. But our patients have an added burden because we need them to grow and develop, but we need to prevent and reverse malnutrition. We want to improve and support them through recovery from treatment, prevent the catabolism of lean body mass, reduce the stress associated with treatment for patients and their families by supporting them, protect against the long-term consequences from a cancer diagnosis and the treatment they receive, but actually possibly most importantly, to improve and maintain quality of life during the treatment and beyond. And something we don't often touch on is actually, we think of, you know, we want calories in, we want them to have enough nutrition, but we want to remember the role that family meals play for families. You know, you think about what you lose. Families come together at the end of the day, they talk about their day, they connect. You know, think about yourselves right now. You might have had a coffee before this. You might meet for lunch after. These are all things that patients lose during treatment because of feeling unwell. They're having frequent hospital admissions. Excuse me. And there's a lot of literature out there to support the benefit of family meals. It improves family relationships. It improves family connection. It has been shown to be protective of mental health for children and particularly adolescents. And importantly, tying it all back together again, frequent family meals equals improved nutritional status. And this is something we're losing. So it's just a little aside, but it's important to remember. So what is malnutrition? I think we all think of undernutrition first and foremost when we think of malnutrition, but very important to remember, overnutrition and micronutrient deficiency also fall under the malnutrition bracket. And it is common to see all of them occurring together. So just because you have someone in front of you who looks overnourished, they may actually also have the dual burden of undernutrition. So it's important not to overlook these patients, but this will be touched on in another presentation. So who's at risk? We all know everyone's at risk of malnutrition, but in particular, the risk of undernutrition, you're looking at your advanced stage solid tumors, your high-grade brain tumors, anyone having intensive high-dose chemo with the transplant, and some of our younger patients. In terms of overnutrition, you're looking at your patients with prolonged corticosteroid therapy or your total body irradiation. So this would be more your leukemias. So Jane's definitely already touched on this. I'm not going to go on about it too much, but what are the causes of malnutrition? So first of all, you have your cancer treatment effects, your nausea, vomiting, your constipation, your diarrhea, taste changes, early satiety, all of these things going on for these patients. And this is kind of what we think of. We think of the treatment that's causing their inability to consume adequate nutrition. But let's consider the effect of the tumor for one moment. So this is a picture of a very complicated metabolic process known as cancer cachexia. And this is a pro-inflammatory state that the body is in, which causes weight loss, muscle breakdown, and fat loss. And this is something that's going on because the tumor is not just an inert lump sitting in their tummy. This is a highly metabolically active mass, and it is secreting pro-inflammatory cytokines that are exerting deranged metabolism throughout the body. I'm just going to focus on three kind of things here because I don't even really understand the diagram completely. But one pathway that is completely deranged is the ghrelin and leptin pathway. So ghrelin is our hunger hormone. So think of like a grumbly tummy, grr. And the ghrelin is downregulated. So the body is no longer sensitive to ghrelin. So the child is not getting hungry. And then also we have the leptin hormone, which is being over-secreted, and that is telling the body that it's full. That's our satiety hormone. So the child is not feeling hungry, and that is something being caused by the tumor. As well as that, normally in the starvation state, the body would preserve skeletal muscle and fat and adipose tissue. But in this state, the tumor and the pro-inflammatory cytokines are causing the body to break these down. So it's a very complex process. And it is why we need to intervene very early in these patients, because it is very difficult to reverse with nutrition support if it is not caught early. And then finally, we have the psychological and environmental effects. I mean, just being in the hospital alone, I always say the four walls of the hospital room is the biggest appetite suppressant around. You always say the kids hate the food is served at different times, they hate being in hospital, they miss their family, they're overwhelmed by the diagnosis, their parents are pestering them to eat. They have learned food aversions because of nausea and vomiting. And then also there can be some disordered eating patterns at home in the families. So it's just to be very cognizant that all of these can have a huge impact on the child's ability to eat. So these kind of three, the cancer treatment, the tumor itself, and then the psychological and environmental factors are huge factors in causing malnutrition in our patient cohort. So how can we monitor these patients then? How can we catch them early? So there are nutrition screening tools that we can use. There are many different types. What they allow us to do is to assess patients regularly. It keeps nutrition part of the conversation instead of it becoming secondary to the medical treatment. And it allows us to find patients early and intervene with a dietetic intervention. But like with all tools, there are strengths and limitations to them. So I suppose pros, it's early identification of the malnutrition. It enables an early referral to the dietitian for the patients that are high risk of malnutrition. It encourages the interdisciplinary team to work together and collaborate. And it kind of standardizes care, and it ensures the patients are being assessed on the regular for their nutrition status. The cons then, so I mean, there's a lack of a disease specificity with a lot of these tools, and they have to be interpreted with caution if they're using BMI as the main anthropometric measure. They offer a snapshot of a person's nutritional status, but if a child has a rapid nutritional decline and you're only doing weekly or fortnightly assessments, then you may miss the opportunity to intervene early. The other thing is that some of them have very subjective questions, so the answers can vary depending on which screener is using the tool. So once we have identified someone at high risk of malnutrition, they are referred to the dietitian, and this is what the assessment that the dietitian uses to monitor our patients during their treatment journey. Dietitians in Ireland use the nutrition care process model, or the NCPM, developed in the United States. And as you can see here, we have to look at a number of factors when we are conducting our assessment, I'll go through now to show you how we work with the teams to gather our information. So number one, we always have to look at the clinical information. And for us dietitians in Ireland, we're very lucky. We're part of the dry round in the morning, so it enables us to have a really good grasp of the child's medical condition, how, what treatment protocol they'll be on, what was the history of their presenting complaint, any past medical history. We have to be aware of these things, and we talk to our medical and nursing colleagues about this. Then we have to be aware of their bloods, the medicines that they're being prescribed, what treatment protocol are they on? We have to know which chemotherapy agents they're on, what are the main side effects that you can expect from them, what supportive medications are they prescribed, what's their compliance like with that, do they take them regularly? Is there anything else that can be done to help if the patient is having, loose stools, or if they're, and they're still taking their laxative? We just need to be aware of all these things. Then we look at their nutrition-focused findings, and this is really where nursing comes into play for us. It's really important when the patient is on the ward that we are aware of their vital signs and their observations. If a child has an increased temperature, that impacts us, because for every 1 degree of increased temperature, that is a 10% increase in their estimated energy requirements. We also have to really keep a close eye on their fluid balance, their ins and their outs. If a fluid balance chart is kept well, and we can see what is the child eating, when are they eating, what are they drinking, and then we're looking at if they're vomiting, when are they vomiting? Is it in conjunction with a medicine, or is it in conjunction with a meal? Then we're looking at bowel movements, when is that happening? How frequently? And this is an opportunity as well for us to talk to our nursing colleagues to see what they think. How do they think the child is eating? Yes, the breakfast went into the room, but did they actually eat the breakfast? Or yes, the dinner went into the room, but did the child eat it, or was it actually the parent who ate it? So all of these things, we have to gather all this information here. Next, we look at anthropometry. So yes, we look at weight and height, although they are not a good indicator of overall nutrition status when looked at as a sole indication of nutritional status. We also look at mid-upper arm circumference. We look at growth trends. We look at, was there any changes in the child's weight before they were diagnosed? Did the parents notice the clothes fitting differently? and like little signs like this that would show that they had a change in body composition over the time before they came to us. And then we would calculate out their requirements. So I'm just going to jump across on anthropometry now. So why is weight and height inadequate? It has been shown to be inadequate when it's used as the sole indicator for nutritional status in these patients, and it risks then underestimating undernutrition. This is because, as Jane touched on before, if they have a large abdominal tumour, that could weigh more than 10% of their total body weight. Also, many of our patients have altered fluid balance. There's hyperhydration is a part of many of our chemotherapy protocols, steroid use, and also then there's an inability to distinguish between lean mass from fat mass. So weight is not telling us everything, particularly in the solid tumor patients. So what could we do instead? We have DEXA and bioelectrical impedance. These are more precise measures of body composition, but they're also expensive. And I don't know about other hospitals, but we don't have access to these in our hospital. And I presume this would be the case in many other institutions, as they are expensive. But what we do have is mid-upper arm circumference. So this is a recommended measurement for children with malignancies. The benefit of it is that it is cheap, it is quick, and it is easy to do. And it's easy to teach. So here we are measuring from the midpoint from the shoulder to the elbow on the non-dominant arm, and we are taking the midpoint there, and we have these colored tapes. You can see a little image of it there above, and we can then measure the child's mid-upper arm circumference. And these are then very helpfully color-coded. So you can see there that each color shows what risk of nutrition the child is. And they also enable us to have serial measurements of the child's mid-upper arm circumference. These measures can be taken weekly, even bi-weekly, to follow a child's nutrition journey throughout treatment, and has been shown to be a more accurate measure of overall lean and fat-free mass than weight, height, and BMI. So this is an excellent way to support the measurements that we use in hospital to track our patients. So then we move on in our NCPM process. We look at number 6, the diet. This is the bit that I suppose people think is what the dietitian does. We go in, we meet the families, we talk to parents and the children about what their usual diet is like. Have there been any changes? Have they developed any food aversions? How are they finding the hospital environment? Are they managing to eat the meals here? Is there anything we can do to help with that? Very importantly, and as Jane touched on in her talk as well, we're finding more and more children having sensory issues with food. So it is important that we establish that early on. And also then in our kind of older adolescents who may have some kind of pre-morbid disordered eating patterns that have been emerging, all very important for us to be aware of. And then based on all of the information we've gathered in the first 6 points of our assessment, we make a nutrition diagnosis and we identify our main nutritional concerns for the patient. And from here, we develop our plan. So just a whistle-stop tour through our dietetic intervention. Our first line is always food first, and we educate people on using a high protein, high energy diet and making the most of every bite and the most of their small appetite. We'd also educate them a little bit about specific dietary needs they may have with taste changes, early satiety, and things like that. Then if they require a little bit of help with their oral intake, we will go through oral nutrition supplements to support them. There's many different supplements that we can avail of. I said this before, but if we were all here together, I would at this point pull out my little shot glasses and make everybody try the supplements, because I think it's really important that we know what we're asking the children to drink. But there is a good selection, and we often find one that suits the child. Then finally, if the child is unable to eat and meet their energy requirements through oral diet and oral nutrition supplements, this is when we consider the support of enteral nutrition. We try to talk about about enteral nutrition very early on with patients so that they are aware that this is a supportive measure that is used during the treatment journey and in no way, shape or form a last resort or a failure on their part. And we ask parents not to use it as a threat to the child. And this is certainly a challenge that we have in our hospital, but I think it helps when all of the interdisciplinary team work together and have the same messaging around this, so that each member of the team is discussing the benefits of enteral nutrition when it's needed, and that it's being brought up frequently to the family so they're aware of this as a potential throughout treatment. And then finally, fourth line, I actually didn't know if I'd put this in because I should have done brackets. We don't have parenteral nutrition is only really used when the gut is no longer functioning. So this would be in our kind of children having intensive treatment in high dose chemo and stem cell transplantation. So this is with GI obstruction or ileus, or if they have intractable nausea and vomiting. But overall, we would always try to continue to feed the child enterally when possible. So that is the role of the dietitian here. We rely so heavily on all of the members from our team, and I'm now going to hand over to my colleague Gráinne Langan, who's going to talk to you about the role of the nurse in the nutritional management of a cancer patient. Thank you.
Good morning, everyone. I'm Gráinne, as Tina said. I am one of the clinical nurse education facilitators on the Haematology Oncology Ward here in Dublin. And I'm just going to touch on the role of the paediatric oncology nurse in relation to nutrition. And I suppose really listening to the two previous talkers, there's a huge crossover in our role. We do an awful lot of liaising, we do a lot of collaboration, and I suppose that's the way the role works very well for the children. In relation to our role, I suppose we have a significant responsibility in the evaluation of an education and monitoring of nutrition in children with cancer. We start off with a baseline evaluation. So when they are presented to the ward first, we establish their dietary habits. So any special requirements that they may have, they may be a celiac, they may be a vegetarian, they may just be a picky eater, or they may have allergies to nuts as well. So we try to get an information gathering to know where they're at the beginning. We have ongoing monitoring, so we are tracking the changes in their appetite. We are looking at weight loss, weight gain, and their growth. And over here to the right, we have a tool that we use on the ward. It's our weight and height tool, and that is to track the children on every admission that they have. So be it a 2-weekly chemotherapy cycle, a 3-weekly cycle, we put in their weight and their height, and obviously that's used to calculate their chemotherapy doses. And we monitor that, and that's used as a tool. It allows for an early referral to dietetics if they haven't been referred already beforehand. We also have the mid-upper arm circumference channel there as well, and as Cliona already alluded to, that alone the weight and height really isn't an adequate indicator of nutritional status, but in combination it is there for us to track and I suppose highlight children early on when there is nutritional losses occurring. Accurate documentation of food consumed and high calorie drinks is really important. So in the intake and output chart, it's really important that nurses are able to document the exact consumption of food. So whether they only have 100 mils of a Scandi shake or they eat half a slice of toast with butter, that helps the dietitian to kind of look at the information and just look at their requirements and see, are they reaching their requirements? And if not, then we need to look at taking action to improve that. It's important that we can identify the risk factors in relation to nutrition for our children on the cancer ward. So immunogenicity of the chemotherapy drugs, mucositis, nausea, vomiting and diarrhea are all really important indicators. And that's just to name but a few. There is numerous other risk factors, as we've heard earlier on as well. But I suppose thinking of things like carboplatin, cisplatin, methotrexate, ifosfamide, all very nauseating drugs. So it's important that we have the background information to understand why we need to improve our care, why we need to add in antiemetics, how to monitor them and how to help them to get through the situation. Education of staff and parents is vital. We need collaboration with the parents. They're going to go home with this child, so it's important that they understand exactly what is going on and why they need to look at their nutritional intake. Early engagement with parents relating to the possibility of the need for an NG tube is really, really important. And it's important to set expectations at the very beginning, particularly in relation to children with maybe stage 4 neuroblastoma. We know that they are inevitably going to need an NG tube. Most probably will require an NG tube and enteral feeding from the very beginning of their treatment. There are the few who may manage for a short period of time, but will no doubt need it. And certainly as they go towards transplants, they will definitely need enteral feeding. So it's really important that parents have that expectation and that we're all open and honest and sharing the same information, because otherwise it leads to confusion. We collaborate with the dietitian in identifying children at risk of malnutrition. And just over here, we have a real team approach, and it's already been alluded to twice, but just to mention again that we have the patient at the very center of everything, and working around the patient is our nurses, dietitian, parents, and oncology team. And it's really, really important that we're all on the same page, that we're all working towards the same goal. When the children are on the ward, we encourage small and frequent meals, and again, it's documentation of what exactly are they eating. We have high-calorie snacks and supplements, and again, it's making sure that we're offering it to the children, that we have availability. But we also need to recognise the barriers to nutrition when they're in hospital. So hospital food is always a big issue. Children always refer to hospital food and how they dislike it. Meal times are also an issue. They're based around hospital times rather than children's times. So a lot of children in the morning time may wake up, they won't eat until about 11 o'clock, and lunchtime is at 12, and they're not hungry. So they miss a lot of the meal times with kind of higher concentration of calories. So these can be difficulties. Pressure from parents. So when children aren't eating, the pressure is on the parents to get them to eat anything. So subsequently, they might bring in McDonald's, or, they're eating at different times of the day. And the children find that really difficult as well, because they're not hungry. And the taste of nutritional supplements, if they're being implemented, there's Scandi shakes or Fortini drinks, and some children just don't like the taste. So it's important when we're offering these drinks that we offer different flavors, we offer alternatives, that we don't just put down that the child isn't drinking or tolerating it. It's offering different supplements to see what might actually work for that child. We provide, the most important thing as well is to provide appropriate antiemetic cover. So like we said before, the risk factors of the mutagenicity of the chemotherapies, it's important that we know which drugs are very nauseating, and we provide the correct cover, and we escalate swiftly, that we don't just carry on because someone's vomiting. We look to see, can we add in extra cover? Because if somebody is nauseated, that can be more debilitating than vomiting itself. So it's important that we ask those questions. It's not just because they're not vomiting, that's more visible. Sometimes nausea is invisible. So it's important that we ask all the appropriate questions, and then we escalate their care. So we add in an extra antiemetic. We always have an antiemetic in the background. So if what we've given isn't giving them sufficient cover, that we can add in another medication to assist that. Because if they're feeling nauseated, they're not going to eat, and it goes into a cycle. Recording accurately any vomits as well, paying attention to the volume, the type, and the frequency. What is it related to? Is it related to when we gave the last medication? Is it relation to motion? Is it relation to antibiotics and they're having vomiting and diarrhea? So looking at that to see what is there some kind of commonality there, or are they just vomiting indiscriminately? Having an awareness of taste alterations, that food that they liked before is now on the no-no list. Dry mouth, infections, fatigue, anxiety, and fasting. So we know there's increased metabolic needs when they have an infection. We know that they're not hungry, they're febrile, they're unwell, they have no interest in food. If they're fasting for a procedure, they could be fasting all day waiting for a procedure that gets cancelled at 4 o'clock, and then they get to eat maybe one meal, and then they're fasting the following day. So recognizing all these issues that are really going to impact upon their nutrition in that day and for that week potentially. Early identification and treatment of mucositis is really important. And we just have over here on the right-hand side the oral assessment tool that we use just to document and to grade their level of mucositis. So we know obviously grade 1, they may be slightly uncomfortable. Grade 2, they're in a lot more pain. Grade 3 and 4, there's no way they're going to be eating. And they won't manage their nutritional requirements during this period, and they will need assistance. Be it enteral, and we'll be looking at enteral feeding during that period of time. But this grading system just helps us track it, and I suppose preempt and intervene early with enteral feeding if that's the required outcome. Early intervention, as I say, and commencement of the feeding. When we go to looking at nasogastric feeding, we have the dietitian very much involved, and she'll devise an individualised plan for that patient. We need to have positive discussions and preparation relating to the NG tube insertion. So the nurses are involved in this, the dietitian is involved in this, and the medical team is involved in this. But we consolidate the information that's given by the team and prepare the child, ensure parents have an understanding as to why putting an NG tube down is really important and what it means for them and what their role will be in relation to this. The NG teaching is conducted by the nurse. They pass the NG tube and they teach the parents how to use the NG tube, we supervise them and we support them while the training is ongoing. We deem them competent, so they won't go home if we don't feel that they have a competency in managing the NG tube. They learn how to assess for pH, for flushing, and for assessing and for attaching the feed. And that's a really important role in terms of nurses making sure it's safety of the use of the NG tube. We provide support and guidance for parents in relation to escalation of feeds and use of water boluses. So parents can often be reluctant to increase the rate up of feeds. They're worried the child will vomit, and it's really important that we're able to provide that support and encourage them and empower them in changing feeds, and also in the use of water boluses, that when the child is at home, if the child isn't drinking, that they can add water boluses down their NG tube, and that takes the pressure off and it maintains the hydration for the child, and it gives a bit more autonomy to the parents that they're able to manage the child at home in terms of hydration. And just also being aware of barriers to eating that we see. So anxiety can be quite significant. Low mood can result in less not eating as much food. Fear of vomiting. So once they've had an experience of vomiting, and that's why I suppose we're looking to have their first cycle of chemotherapy as positive as possible to ensure that we've maximised their antiemetics. And to minimize the amount of vomiting. If they don't have a good experience, they can often return to the hospital having not eaten much and then starting their next course of chemotherapy, not wanting to eat because of the previous experience, and they can develop an anticipatory nausea. So really important to kind of ensure that we kind of get it right the first time. And lack of control, I suppose, particularly for the older children, the only thing they control is diet. So just being aware of that. Parental and patient involvement is really, really important. It's vital to achieve good nutritional status, and then psychosocial support again is ongoing and really, really important. And that is it for the minute. I will pass you on to my colleague Merlin Menes, and she will talk to you next.
Hello, everyone. Thank you for having me today. My name is Merlin, and I am one of the shift leader in St. John's Ward. I'll be talking about the warning signs during a phone triage. As the National Cancer Center, we receive calls from parents across the country. Our phone call triage system works 24/7, ensuring constant support. Interestingly, the majority of the calls come after 6 p.m., as during the daytime hours, the CNSs would be dealing with all the phone calls. We also receive phone calls from 16 other shared care centers from various members of the MDT. Before we proceed, it's important that we as nurses or the wider MDT remain aware of the key signs and symptoms of poor nutrition and dehydration that may lead to the child being brought to the hospital. So the red flags for diarrhea is persistent diarrhea, blood or mucus in the stool, signs of dehydration, lethargy or altered consciousness, high fever, severe abdominal pain. The red flags for constipation and poor intake is no bowel movements for more than 3 days, severe abdominal bloating or pain, refusal to eat or drink, nausea or vomiting, hard palate-like stools or painful defecation, loss of appetite with decreased energy, visible discomfort or straining, and associated urinary symptoms, example like UTI. The red flags for swallowing difficulty is coughing, choking, or gagging during feeds, wet or voice change after eating, long meal times or tiring easily during feeds, painful swallowing, drooling or pooling of saliva, and refusal to eat despite hunger. Now I'll walk through some examples of calls we receive from our parents and how we triage each situation. So in examples for vomiting is some parents will call and say vomited 3 times despite regular antiemetics, vomited 2 times small amount with abdominal pain post chemotherapy. Ondansetron is administered, but vomiting persists. So in this scenario, we always begin by taking a brief history of the parents or the patients. This includes asking the child's diagnosis, particularly to determine if this symptom might be related to a brain tumor or a shunt issue. We also consider the child says has those under the age of 2 are high risk for dehydration. We also ask about the child's weight if known to help the calculate fluid requirement. We then check when the child was last admitted to the hospital, which helps us to determine if there was any recent received chemotherapy that might have triggered this vomiting, delayed vomiting. After gathering the background, we ask specific questions about vomiting. How many episodes, whether they are large or small, or if any anti-sickness medication is given. If so, what medication it is, how often is it given, whether the child has vomited immediately after giving, since in that case, the medication may have not even been absorbed. We also assess whether the child is able to eat or drink despite the vomiting. By the end of this conversation, we usually are able to decide whether the child needs to be brought to hospital or can be safely managed home. In next scenario, which is oral intake and hydration, parents will call eating very poor, child is only sipping water, or mostly in teenagers, the teenagers will tell the parents like, we have observed dark colored in urine, is there anything to be worried about? In this scenario, again, we ask by taking a brief history, followed by specific targeted questions. For example, what's the child's weight? If the child, for example, is a 10-kilo child, the fluid requirement is a liter. We ask the parents how much the child has had. If the intake is below, we ask them if the child has an NG tube to give water boluses via the NG and to maintain hydration. Gastro symptoms like constipation for 3 days with discomfort and reduced intake, or ongoing diarrhea with severe abdominal pain and sleepy. So in this scenario, again, history taking is very important. But for constipation, we recommend high fiber diet along with the use of laxatives to promote bowel movements. And for diarrhea, to maintain hydration, as we have mentioned before, but also for pain management, we use pain medication for abdominal cramps. Oral mucositis. And in the following slides, I will show you how we assess oral mucositis. But if the parents on the phone call are like, there is mouth pain, coated trach, drooling, minimal to no intake. So in this situation, we assess them on the phone. And if there is any pain medication that can help, we do that. And even in spite of all that, if nothing works, then we ask the parents to bring them to the hospital. A very common phone call we always have is regarding feeding issues with the NG. That is, either there is no aspirate obtained or only, for example, there is no aspirate obtained or there is high pH or the NG is out post-vomit. So what do you do in this situation, especially when the call is at like 12 a.m. in the middle of the night? So in this case, we ask the child to take water or milk or any drink and recheck the NG in 30 minutes and see if that works. We also need to find out what is the purpose of this NG. Is this NG for medication or is this NG for feeding? So if this NG is for medication, is there any medication that's due at 12 a.m. that night, or especially any seizure medication the child needs to be taken at like 7 in the morning? In that scenario, the child has to come to hospital. If there are no medications due, the child is okay to stay home. If the tube is used for feeding, then we find out how much the child has eaten during the day. And if the parent is happy with the child's intake during the day, we tell the parents to keep the child overnight in the hospital and come the following day for an NG insertion. We always try our best to keep families at home, but if the child needs to come to the hospital, they must. NG tube insertion isn't a simple procedure. We always have to check a recent FPC level if it has been done. And if not, the child needs to come to the hospital. We need to do their full blood count. Our criteria over here is platelets above 20. So if the platelets are less than 20, we have to administer a pool of platelet, which takes another 1 hour. And that's after that when the NG insertion happens. So all this process might take 3 hours. So it's not fair on the families to come at 12 and be in the hospital till 4 a.m. in the morning. So assessing is really important. So we try our best to keep them in the home as much as possible. But if any reason, if they have to come, they have to come. So when to escalate? In spite of giving all the advices on the phone, there is persistent symptoms. They need to come back. In case of severe concerns for dehydration or malnutrition, NG dislodgement, depending on what is the purpose for it, vomiting after medication, that means they need IV medications to manage the vomiting, and caregivers' concerns or inability to maintain intake at home. Parents are already stressed, and we giving support on the phone is very important. But in spite of that, if they feel that they cannot manage it, then we ask the parents to bring the child. But at the end of the day, we always consider caregivers' consent as a valid indicator, because we always think the parents are the right judge person who can decide whether the child is safe at home or needs to be brought to the hospital. So this is a telephone triage that helps us to gather information, and following day, the CNS will call the parents to check if the child is okay. So this is where we take all the details of the family and the patient diagnosis. These are all our 16 shared care hospitals that were mentioned in the earlier slides. And we triage them based on what symptoms they could be for. So we can take an example of mucositis or constipation, nausea, vomiting, and then what advices we have given. And at the end, on the following morning, the CNSs will follow up and call the parents and see if they are okay or if they need to be brought to the hospital. So it's always rechecked by a second person to make sure the family at home is safe. We have question charts beside the phone to prompt staff and help them with the relevant information. So this is for nausea and vomiting. So it's always kept beside the phone. So in case if even a student nurse is answering the phone, or like a junior nurse who's only new to the unit, and if receives a call for nausea and vomiting, just get this chart out and ask these questions. That gives us enough information, and then we can advise if the child needs medication or fluids or antiemetic. And likewise, we also have a chart for constipation that allow us to assess the child and then to see what advices we need to give them. And we also have the chart for mucositis, because mucositis is very difficult to assess on phone. We normally have to see it, but these questions help us to ask the parents, and that gives us an understanding if the child needs to be brought to the hospital or if the child can be managed home. So that's me. That's the summary for today. So incidence of malnutrition is high in pediatric cancer patients. Causes of malnutrition is multifactorial. Appropriate screening and early interventions has been shown to improve outcomes in patients. Screening tools are useful in identifying patients at risk of malnutrition. Optimal nutrition improved the quality of life during and after treatment, and collaborative working and unified messaging between transplant, nursing, and medical professional essentials in order to provide optimal care to our patients. Thank you, everyone. And if there is any question, we are all happy to take it. Thank you.
So thank you, Tim from Ireland. If I may ask the speakers to turn on their cameras, and we will go into the discussion, question and answer stage. So if you turn on your cameras, Cleona and Tim, are you going to merge all into one before a camera? Yeah, for other attendees, if you want to turn on your camera, it's fine. We will engage in our discussion and questions. There are a few questions posted on the chat. And if I may ask the first one on behalf of Caroline Rooney. She's asked, do you recommend the use of probiotics? And I think Caroline is here as well. I don't know whether she's left, but she's still here. Then she can take the answers from you, your team. Who would like to answer this? Do you recommend probiotics?
Yeah, I can answer. Hi, everybody. Lena again. So at the moment, we don't recommend the use of probiotics. And that is more because of a proof, or what is it, absence of proof as opposed to a proof of absence. I am aware of some institutions doing trials using certain strains of probiotics as they're thought that they actually may be protective of the gut microbiome and helping with dysbiosis during treatment. But at present in our hospital in Ireland, we do not recommend probiotics.
Yeah, it is a very, this question has been asked quite a few forums across SIOP Europe and also via CCLG, our national UK group. Caroline, do you want to reach out for any more question following up from that? Or do you want to offer a comment? No? Okay. Let's go on to the next one here that I have. Teresa Slavin asked the question, hospital food is often described as being not nice by the children or teenagers and they won't eat it. Any suggestions how to make hospital meals or eating in hospital more fun to encourage the children to eat?
Hi, it's Jane here. I trained in the UK and I was aware when I was training that there was a pilot project in Edinburgh and Cambridge where they had a chef available with a hot food station. You could whip up pancakes, omelets, other food that might be more appealing to children than the fare provided by the hospital canteen. So I'd love to see that happening for us. And of course, the beauty of that is it's prepared fresh, it's hot, it's made at the time that the child is asking for it. Because of course, it's typical that they're not feeling hungry when the meal trolley comes around. So I think that would be one avenue that we could pursue, and I'd be very much in support of that. My colleagues might have other ideas as well.
Hi, it's Gráinne here. One of the other initiatives that we have in the ward is with the AYA group, and they organise pizza night and kind of treat nights for the teenagers to kind of encourage them to eat and share food with each other or their friends. That's one of the other initiatives. But I think other than that, we're a little bit stumped with extra bits and bobs.
It is very challenging when the children are feeling unwell. And all of the other things that we talked about in the talk that go against the child being able to eat during their admission. I think one other thing is if it was possible to have a space in the rooms where people could sit together, talking about the family meal experience and coming together and watching a parent eat or a sibling eat. It's what they're missing out on during their admission. So it would be nice if we had that, because we don't really have that in our hospital rooms at the moment.
Yeah.
Some of the teenage at-risk units, they do have dining areas where the teenagers can book a room, they can have a dinner party, they can make their own food, they can order the food in. And it really encourages that communal atmosphere. And when we move to a new hospital, we're going to extend or increase our age range, and that's something else that we can look at for the future.
And also we'll have more availability of food at times that people are hungry, because currently the hot food comes at the time that the hospital dictates. Whereas in the new hospital, we're hoping that there'll be food made on whenever the child is looking for it as such, up to a certain time frame, I would assume, but that's the plan.
Yeah, but it is a difficult topic, and I am aware there are some centers across Europe that do food on order. So I visited Princess Maxima once, and in Gosh we tried a period where some time ago in BMT patients we had their dietitians coming by the ward to ask what food the child would like to eat, and they go and prepare it to it's certainly not as nice as the home cooked food, but actually it's an attempt to provide food that is to their liking. Okay, so now I'm going to ask another question that was posted on the chat, and that question is from Kiara Kennedy, your colleague. Do you stop enteral feeds in HSCT, i.e. bone marrow transplant or stem cell transplant, when a patient shows signs of gut toxicity? So it's elective stopping food. Yeah. What is your practice?
So I can take that again. We do try to keep some form of trophic feed going in our patients in transplant. It has been shown to be very protective against developing VOD, and also to keep the gut moving and keeping gut motility going to protect against bacterial translocation. Just when they have the mucositis and they're sloughing off all those cells, that the feed is actually protective, and it also is keeping all of that moving through their system. Obviously, there are some extreme instances where enteral nutrition is not possible, but really and truly, we would always try to keep something small going through because of the protective effect of enteral nutrition that is, well documented in literature. Kira.
Yes, yeah. So I agree that the recommendation is to keep the gut going and to encourage enteral feeding. And but I'm also aware in some centers they will electively rest the gut in bone marrow transplant due to the severe damage that is on the gut lining when they receive their treatment. So different practices, but it's good to bring it up to the discussion platform. May I just ask one question here? So I like the idea about the nutrition care process model. So for our nurses colleagues here on this call, what advice would you give to ensure that this model is used or helps them in the care of patients, cancer patients?
Well, I think it's really nice to be able to describe the assessment that we do and what we're looking for, and how we rely on the nurses' documentation and their monitoring to enable us to conduct our assessment. So really and truly around like being, taking a good fluid balance, or, or being aware of, like I said, not just the meal going into the room, but actually is it the child eating it? Are they eating any of it? And then sometimes you can have patients that maybe overestimate how much the child is eating just to protect against the NG tube becoming atopic, or parents who are underestimating what the child is doing because they're highly anxious about their nutrition. So the nurse has like a bird's eye view of everything that's going on. They know exactly what's happening. And I think as well, they can often say one thing to the dietitian, because they say what they think maybe that I want to hear, whereas they will say something completely different to the nurse that's with them all day long, because they just have a better, a closer relationship. So the nurse's information is actually what is so valuable for our assessment. It gives us a great all-round picture of what's really going on.
Yeah, good. Yeah. So it's accurate recording, isn't it, of those information that is vital to inform how we manage nutrition in cancer patients. Have you ever experienced in your center any religious dietary restrictions?
Yeah, absolutely.
And how do you practice trying to manage their nutritional intake?
So we have a diet kitchen that's able to prepare food specific to people's religious beliefs. So we're lucky with that. So that's where the admitting nurse will always ask, are there any special dietary requirements for the patient? I would say we could do better on the taste of some of those meals, but we do provide the food that families eat. Absolutely. There can be issues actually with some of the supplements, though. We've recently learned for strict vegetarians, some of the feeds, actually a lot of the feeds contained fish oil, which they would prefer not to have that, obviously. And that is problematic because many of them include them because of the omega-3s, which are so protective and anti-inflammatory. But that is a problem because it seriously limits the options that we have for those patients from an enteral nutrition perspective.
No, but we can always march on with projects to speak to those companies.
True.
To see alternatives.
Absolutely, yeah.
Yeah. Okay, so we're about to round up. May I just quickly ask your telephone triage, the warning sign triaging the calls coming through, is it from 6 p.m. to the morning hour? And is it based on the ward?
Yeah, so it's on the main ward, and the phone is actually 24/7 running, but normally during the daytimes we don't hear that phone ringing more. So it's after 5 p.m. and it could ring until like 8 in the morning, and then after 8 or 9 we would have CNSs that could help us.
Yeah, I think I like the idea. I don't think many hospitals have the benefit of that 24 hours, telephone triaging patients' questions. So that's very good. Now, we are about to round up. For some of the latecomers, we have a second webinar lineup, and you'll soon get details of it. So do feel free to join. Are there any more final questions for our presenters? No, I don't see any hands up. Yeah. Okay. So, if you have not already done so, please put your name down in the chat with your job and your country as we monitor statistics of these initiatives. You will find them helpful, and I'm going to share with you the link of the feedback survey again. It is important that we have the feedback. Can you see this screen here? Can you see the screen?
No, Mary.
No.
Okay, that's fine. We'll put the link on in the we'll put the link also on the, can you see this link now on the chat? I'm going to put the link on the chat so that you can see that. Okay.
No, yeah, there's no link on the chat.
Wait, let me put it in. Cleona, you can share your last slide because they will be on that link on that.
Yeah, no problem. Hang on 2 seconds.
Can you see it? I'm putting it now, the feedback. Yeah.
Yes.
So that link, if people could click on the link and do a little quick, it's not too long to do it. Okay, and for those who are not PsyOp Europe Nursing Working Group members, it's very easy. You don't have to pay, just click on the link there and just join. So that's the evaluation survey. And then I will share with you, try to share with you the slide for the next registration. The next registration link. That is the webinar 2. Too many things on my screen. We will send it if you can't click on this link now. So we'll send it on. Okay. So can you see the link for the next webinar, which is on the 17th of June? Thank you. Thanks very much for your participation.
Thanks for having
Clear now.
us.
Can you see that link or not? Sorry, can you see
Yeah,
that
we
slide?
can now. Yeah.
Because
Yes,
it's one
yes.
screen, so it's difficult. Excellent. So I'll leave it on for a while, and people, if they want to leave, that's good. Thanks, presenting team. Thank you very much. We'll be in contact soon, Cleona and team.
Lovely. Thanks very much for having us. Thanks for
Thank
coming,
you.
guys.
Bye-bye.
Thank you. Thank you. Bye-bye.